Well, thank you, and welcome from San Diego, California. Pretty exciting to be able to share ideas from this distance. So, we want to talk about technologies for treating chronic pain, and I think I maybe should just share a little bit about who I am. My practice is limited to treating chronic pain injuries and breathing disorders. I'm board certified in both of those categories by various organizations. Immediate past president of the American Academy of Craniofacial Pain, and so I'm here today to just share some things that are helpful, that simplify the delivery system. And I do want to share that the views and things that and the information I'm sharing with you is not solely from my practice here in San Diego, but it's also from the 65 other sites that we have around the world because we've standardized the protocols for treating patients in this way. And so we're dispersed throughout the United States. We're in Canada, throughout Canada, coast to coast, New Zealand, Australia, and the UK. We have office in London and two other offices there. We're in Dubai and also Bahrain. So we are 65 centers strong, and they are standardized protocols that we use for data collection, for literature, and various research projects that we do. This is an article that I wrote last year for the Journal of Orthodontic Practice, treating chronic pain and breathing disorders with technology. One of the first things I'd like to talk about is joint vibration analysis, basically how we discern the pathology of the jaw even before we have imaging. And of course, imaging is very important, so we'll talk about that, and even the possibility of healing of structures as these photos here are showing. And then we want to talk about the therapies, so laser therapy, healing lasers. These are techniques that will accelerate healing, reduce pain, inflammation within minutes. Very, very important to the practice. Printed appliances. This is something new where we are able to use biocompatible materials of various designs for both pain and breathing, and evaluation of the airway. So we use it's basically sonography kind of imaging where we're bouncing sound waves through the pharyngeal areas, also the nasal. So this is in the pharyngeal area, that's called pharyngometry. In the nasal area is called rhinometry. Those are measuring volume. And then we measure flow rates because you're going to see the correlation between nasal obstructions and chronic pain issues. So we'll show how to manage that. Digital evaluations of bite, T-scan, timing and frequency are necessary instead of just colored paper. And of course, the evaluation of the efficacy of treatment using home sleep testing devices are all covered in that paper. So you might wonder, wow, there's a lot of overlap here between breathing problems and pain, and you couldn't be more correct. This is a paper that I wrote for the pulmonary journals a few years back on the comorbidities between chronic facial pain and obstructive sleep apnea. And so there's a very high overlap between TMD issues and OSA. There's also very high comorbidity between primary headaches and OSA. So that's your migraine, tension type, and cluster headaches. There's a very high comorbidity between primary headaches and TMD. Migraine is the most common headache associated with TMD. And we also have the chronic widespread pain like fibromyalgia. This is highly comorbid with breathing disorders. So when you're dealing with one, you're usually dealing with the other. And so I kind of want to get started off on this presentation today on that foot, because we're going to have some kind of joint pathology in these various chronic situations, and joint vibration analysis is going to be helpful in letting us know what we're dealing with and to a greater degree than just x-rays can give us. So the point is that all joint sounds are pathologic. They in themselves are not the biggest concern. However, the origin of that orthopedic dysfunction, what is the origin of that parafunctional activity that then produces these kinds of pathologies? That I'm looking for origin. And when you treat in this way, you get a cascade of relief that makes treating people so much easier. For instance, on the left-hand side, you see quiet joints. Well, one is normal. The top left is normal. The disc moves with the condyle and throughout its movement. That's proper. But then on the lower, you've got a disc displacement without reduction. And in this case, the disc is out of place or dislocated joint throughout full range. And that's quiet as well. And it can be stretched out so far that ranges of motion are similar. So one's pathologic, one isn't, but they're both quiet. And then you have joints that make noises. So those are usually recapturing disc, and the upper right corner is showing you an anterior disc displacement with reduction. Whereas in the middle video, you'll see a medially displaced. They're very different to treat. One, if the goal is to reposition the disc, well, certainly the upper right is going to be much easier to do. And what we often see is the osteoarthritic, the crepitus bone on bone. And so we're able to help people with those conditions as well. And so this is a very simple technique. We're measuring vibration. Normally, a joint should move very smoothly and with synovial fluid in between the cartilage represented in the top here. So very little vibrations. However, when cartilage and loss of synovial fluid produces a roughened surface, or when it gets to the point where it's perforated and you have osseous contacts, we can record those vibrations. So we'll know a lot more information about the health of the hard and soft tissue even before it'll show up on an x-ray. So basically you're using a transducer that's embedded in silicon that then picks up the vibration. And because there's no air interface, there's no loss of the signal. And in fact, it repels, sounds that are ambient from music or talking or whatever might be going on in the room. And this is very different than sonography, which is basically a microphone. So the vibration of the tissue would have to have great amplitude to then disrupt air for the microphone to be able to pick that up. And also it would pick up speech and music playing or whatever is going on. So not very accurate. So I just wanted to explain the difference between those in case you've heard of the other. So basically, we would see in a normal joint, smooth movements, opening and closing. So here, this is showing closed and then open, closed. And at the closed position, these vibrations are teeth touching. In a normal joint, there shouldn't be any vibrations in between these contacts. And so that also gives us an understanding if one vibration is greater than the other, then we know the occlusion is heavier on the other side. On one side or the other, and we can define that. So in a normal, smooth, functioning joint, you'll see there's very little vibration. However, in a disc displacement with reduction, you'll see a very high amplitude, low frequency vibration. So that's all soft tissue movement. And so we can actually quantify. So here's the disc moving, popping into place, and you get a visualization of how that works. Also, if you have a degenerative joint, you get a high frequency, low amplitude, signaling that this is a jaw that is broken down. And again, we have a frequency that is greater than 300 hertz. From 0 to 300 is soft tissue vibrations. From 300 and on are osseous. So what would be the clinical, use? Well, basically any type of joint pathology or restriction of movement, screening for orthodontic cases, reconstruction cases, airway, obstructive sleep apnea, upper airway resistance, snoring, bruxism, you name it. Basically anything that you're going to stick in somebody's mouth and you want to know what's the health of the joint before you start, I think that's important. Well, let me just demonstrate this to you with a case. So here's a patient with disc displacement with reduction, and that's her primary chief complaint. So her chief concern and reason for that visit was jaw popping and the difficulty in opening. She really wants to stop that displacement. So I explained to her that she has a dislocated jaw, and when she opens her mouth, that the disc pops back into place. And I said, you know, this is going to continue. So and someday, who knows? Maybe it'll be completely displaced without reduction. You can see that she's had various night guards and anterior repositioning appliances, but with no resolution of the problem. I also look at other things. So I'm looking at the fact that frequent cough might indicate mouth breathing. She also has heart palpitations, and cold hands and feet, gives us a sympathetic stimulation to her case. She also has headaches, but she didn't mention as a chief complaint, but certainly does in the temporal area, back of head and forehead. And so this is how she describes that she has moderate pain in her face, the back of her head. So the elevator muscles and the extensor muscles at the back of the head. And this is so often with these patients with forward head postures from inflammatory problems of the jaw. So we take posture photographs, and the object is to split the person's hips with a plumb line and to see if it goes through their nose. But in this case, you can see it's going through her right eye, and that's because she has scoliosis. Okay, and so this is her occlusion, and you can see that she's got some tori, so we know that there's a lot of anterior tongue thrusting. And for that to happen, there's usually nasal obstruction. So this is the panoramic view, OPG, and this is the view for the condo-fossa relationships. And so, so you can see less joint space there in both instances. And so this is what a report looks like from a JVA, and you can see that there's a considerable amount of energy here. So this is the left joint, this is the right, and so we measure up this total energy under this, and that's called total integral. And so anything over 20 is a pathologic situation. So you can see that she's 315 on the left and 121 on the right. So there's significant bilateral disc displacement with reduction. What is likely origin? Well, probably mouth breathing, because you can see that her nasal structures are completely swollen. So there isn't likely air to be able to get through there. She's got something called concha bullosa, where you have the pneumatization of the middle concha there, middle turbinate, that then blocks airflow. So you have soft tissue hypertrophy, and then you've got this bone. And so the inflammation in her case is so predominant that she needs to be decompressed both day and night. And we have concerns that we know that there's a nasal problem, and that usually leads to clenching, and that's her temporal issue. So we treat people for 12 weeks. At night, we use printed appliances like this. These have nasal dilators. They go underneath the nose, lift up like a Cottle's maneuver to open the valve. And then with nasal spray, we're able to shrink the tissue. And using an anterior disc-gluting technique set to the phonetic standard, which is a technique I've published in the sleep literature as a way to find position for keeping airways open. And then we have a day appliance that she wears that's set to a phonetic standard so that speech is clear and holds proper orthopedic function. So just 4 weeks later, she has full range of motion, 57 millimeters of opening. She says that difficulty opening, facial pain, and headaches are almost 100% gone, but the joint noises are 0% changed. And I thought, that really doesn't make sense for you to have such significant relief of all the other symptoms, but the primary one not addressed. So I took a joint vibration analysis at that point just to document. And these numbers show us that we've recaptured both discs. Now we're down to 25 and 31 from the numbers that we spoke of earlier. So this was a case where I show this because it was really difficult, because sometimes patients don't remember things or they can't quantify. And it's good to quantify what's going on, because I didn't want to get in an argument with the woman to say, well, of course they're better, but there's no objective proof. So at maximum medical improvement, which is 10 to 12 weeks in our practice, because I've demonstrated and I took a new JVA at this point, you can see that joint noises are now 100% resolved, as are all the other symptoms. So now we began the weaning process, and now we have stability of the jaw joints, and we can prove that. And so this is the position that she had with the decompression appliance. And now we transition them back to the original occlusion. If you go greater than 12 weeks, you run the risk of the condyle fossa going towards each other, and you'll have dental changes. So you want to stay within that. She still has this bony obstruction, but she's going to be dependent on nasal sprays. And also she has a nasal valve compromise. So first point of entry on this woman is blocked. She has to, that's why she needs to dilate. If we get people breathing through their nose and not their mouth, then we don't run into these situations of disc displacement. And we published a paper on that I'll share with you. But now you can see how uprighting of the body occurs. I published a paper on this about 15 years ago on uprighting the head. When using this decompression technique on these patients with inflammation in the joint, we demonstrated that we were able to upright the head 4.43 inches. So for every inch the head is forward of the shoulder line, it adds 10 pounds of weight to the cervical lumbar spine. And so now you can see if we split her hips, this goes right through her nose, and we've uprighted and aligned her in this process. Sometimes it's easier to see side by side, so I'll show you that here she's going through her eye. This line goes right through her nose. So these are ways that we can document how the jaw joint affects the whole body in posture. These are the X-ray machines that I have in my practice in San Diego and Dubai. For years, I was flying to Dubai once a month to treat patients there, and before we had an associate take over. So, the same imaging, the same techniques work everywhere. Why is imaging important, and how much of the head should we look at? Some people believe 8 centimeters, others say, well, you need to look at the whole structure. The American Dental Association published this paper about 7 years ago talking about the frequency and nature of incidental findings in cone beam computed tomography. And so they were saying that incidental findings are detected relatively frequently in CBCT imaging, and considerable variation is evident in their frequency and nature. The majority are extragnathic findings, that is, those found outside the region of dentition alveolus, thus emphasizing the need for complete and proper review of the entire image, regardless of field of view or region of interest. So I think that's an important. And now, what are the things that we're likely to find? Well, the most prominent are airway related. You're going to see mucus retention, conchobulosis, sinusitis, deviated septum, nasal antral polyps. What is the next most frequent category? Jaw joint related pathology, then vertebral, vascular. So you can see that these two have high comorbidity. We're publishing a study right now of over 1,400 patients from 17 of our centers that demonstrate over 90% comorbidity between nasal pathology and facial pain complaints. And so that's why we need imaging, because you never know what you're going to find. In this case, with this patient with a very elongated styloid process indicating repetitive movement over the years, she came to me as a result of a motor vehicle accident, which we were able to help her with in a non-surgical way. And but the reason for the elongation there was severe nasal obstruction. So just that constant mouth breathing, pulling on those structures, the stylohyoid ligaments and muscle, and the stylomandibular ligament, stylopharyngeus muscle, and styloglossus muscle are all affected when you have these kinds of actions. So you never know what you're going to find, and that's why it's good for us to take a look and just see that what's under the tissue. is it this cosmetic, correction that is producing facial pain, or is it a pathologic process? In this case, this woman had obstructive sleep apnea, nasal obstructions that were resulting in her changing bite and facial pain, and it had nothing to do with the implants. So we tend to look at the first point of entry. We evaluate the nasal valve. Is the first point of entry open? Is the nasopharyngeal tissue open? If not, then the person has to mouth breathe, and then there will be consequences. We look down the velopharynx all the way down to the oropharynx to be able to discern whether or not we have patency, especially when we're treating people for these problems. We need to know whether we've affected them. So this is really important part of the process, and very difficult to be able to deliver this kind of care without imaging, and wouldn't attempt a case without it. Here's a good example. This young boy came, mom brought him in. He's falling off the chair, so sleepy, can't open his mouth, and very, very wide, just, limited opening. And he's already been to a physician who prescribed antibiotics and antihistamines for him for his, what was thought to be a sinus infection. He'd been to a dentist who was going to make a night guard for him. And I'm looking at the face and thinking, well, this is certainly greater than that. And when we take the x-ray, we saw a huge space occupying lesion, which required immediate referral to surgery. I'm sorry, I don't know how that ended, because I've never heard from this patient's mother again, but you can see the lesion's so great, it's separating the zygoma at this point. So that's why it's very important not to guess about anything. And, the thought that how would you know you need an x-ray before is not possible. All those people who treated that young man, they didn't take an x-ray, they didn't know what they were dealing with. I don't know if that cost him his life, but it's certainly very terrifying. So, we really have to look at 4 points of obstruction in order to treat people for facial pain. And so that requires understanding, if you're going to treat somebody for obstructive sleep apnea, the 2 biggest factors in the success are BMI, body mass index, and nasal airway resistance. And so that's what you need to look to. I wrote this article for the Journal of Orthodontic Practice a few years back about the value of CBCT and minimizing orthodontic relapse, and giving explanations as to why we see these problems. Because if we have a tongue elevated above the plane of occlusion, blocking the airway, scalloping on the lateral borders is 70% predictive of OSA. Nasal valve collapse, concha bullosa, all of these adenoids, lymphatic tissue blockages, they're going to result in anterior open bites. Here's a young man, 18 years old, has had orthodontic treatment, bonded 3 to 3 upper and lower, and his tongue still pushed these teeth apart because you can see it's completely nasally occluded. Here's a 40-year-old dentist who has 3 to 3 bonded on lower, 1 and 1 bonded here anteriorly, and the tongue has just moved these lower group as a unit. And you can see she's got a broken tooth back here, clenching. And these are all hallmark symptoms of a breathing problem, the elongated styloid processes. It turns out she's a moderate apneic after we did our testing. To understand this open bite technique, we go back 40 years to Dr. Harvold in the orthodontic literature, where he took primates and put silicone in their noses, and what he found is they developed open bites. And even after he removed the silicone, they still maintained those open bites. So now we're seeing in the ENT literature, otolaryngology, that nasal obstruction may alleviate the bruxism related to TM disorders, because the frequency of nasal airway obstruction is quite high. 67% for nasal valve compromise, 76% for septal deviation, 72% for inferior hypertrophy. And of the people who have had nasal surgery, very few have had the valve corrected. And so the ones who continue to have issues are the ones that the valve has never been addressed. And it's interesting because if you look at numbers, in the US, we know anywhere from 40 to 75% of the adults have some sign of a TM disorder. So the numbers overlap quite highly, and that's the paper we're writing currently. So we know that sleep is going to be disturbed by inflammatory problems. We know that we're going to get postural changes when people have to mouth breathe, and also jaw dislocations. This is a paper we published a few years back talking about the comorbidity between headache, jaw locking with daytime sleepiness or fatigue from poor sleep, nasal obstruction. And so I wrote this paper along with the dean of the dental school. We had 11 of our centers involved in the process. The IRB was from the University of Tennessee. And I was, at the time, running a pediatric sleep breathing clinic at the university. And in this paper, we had almost 1,200 patients. We used the Epworth Sleepiness Scale, which is the industry standard for evaluation. Our intake included questions of pain in the face, as well as sleep disturbances and symptoms. And as a result, we found that if you have an Epworth scale greater than 6, but less than 9, you have 1.39 times greater risk for headaches and jaw locking. And here's an example of that. Here's a young girl, 17 years old, can only open 30 millimeters, and has been that way for 7 years. So she was treated by orthodontic practice and the Loma Linda Dental School here in California without any increase in range of motion. Two surgical techniques, arthrocentesis, were tried and failed. And then they told mom that this young girl needed a total joint replacement at 17. And that's where mom started looking around for alternatives. We're a more non-surgical technique. And so she's looking to be pain-free. She's looking to be able to have her teeth come together in a proper way. We do a standard Bears screening tool for breathing disorders on all children. And we found positives in this test. So she has pain as well, in the throat, in the back of the head, in the masseter muscles. What does she want? She wants to be pain-free in her jaw. She wants to have straight teeth and a comfortable bite, and what anyone would hope for. She's living on Advil and Tylenol. There's now anxiety has come into the picture. She's suicidal. Mom's quite worried about her deteriorating mental state, and she even has low back pain. You look at vitals, she's completely normal on that end. She's inflammatory. Pretty much every muscle you touch or structure is either severe or moderately painful. So 30 millimeters on the day we met her, and identified, here's her anterior open bite. She only is hitting on the second molars, and that's her maximum opening. And so you can see that if we look at these patients, you don't see an airway. You should be able to see an airway when a person opens their mouth, but hers is blocked, so I suspected a sleep breathing component to it. So she has postural issues like the other, but in her case, I diagnosed a disc displacement with a reduction left and without reduction right. And if you look at her imaging, you can see the severe osteoarthritic left condyle. Here's a better picture of it, and you can see how much of that condyle is gone and how aggressive. So in this case, you'd likely think that we had little ability to be able to help her with this situation. Elongated styloid processes, even from a 17-year-old, indicating a long history of these conditions, and a very narrow airway, about 104 millimeters square, and that's quite narrow for any age. And so to understand why her teeth wouldn't fit together and why they've been pushed apart after orthodontic treatment, you can see that the nasal valve is compromised here. She has vomer swell body, inferior turbinate hypertrophy, so completely blocked nasal mouth breathing. So what we did is we had her start a regimen of Flonase, before bed. Nasal dilators, mute. Put her in a orthotic device. It's a myofunctional technique called myobrace. And this initiates and blocks mouth breathing and initiates nasal breathing and gives decompression for the jaw so the tissue, disc tissue can reposition. And then we have a temporary little device that we use in the daytime called an aqualizer, the fluid-filled bags that then decompress the jaw to prevent. Just 2 days later, we had her up to 40 millimeters. And then we were able to insert a positioned appliance for her in the daytime and one for nighttime. She wore those for 10 to 12 weeks. Then with a 60% reduction of pain, range of motion increased to 45 millimeters at this point. And then 3 months later, after we had weaned her off of the day appliance, so she's only wearing the night, now she reports a 90% reduction in all of her symptoms. But at this point, I had asked for a sleep study. And it turns out that, here's the sleep study. It turns out she doesn't have a respiratory problem with sleep, but she has a very big problem with periodic limb movement, 23.5. Anything over 15 is usually treated with medications. But sometimes in women and men too, there can be low iron levels. And so the solution can be as simple as iron supplementation. So, that's what they're looking at to treat her with. So to understand problems of the nose, you can look at an x-ray, you can see it's obstructed, but can you change that? Is this osseous structure going to not completely block the airflow, or is it soft tissue that you can change? Well, by using rhonometry, which is the sonar to be able to measure the volume of the nose, then we can discern that. So here's a graph. The lighter blue is the baseline. This would be the inferior turbinates, middle turbinates, and superior turbinates as you're going back through the nose. And so there's not a great difference after spraying this person's nose. There's a small increase. But because people channel right to left, you'll see a greater increase on one or the other side, depending on where it is. And so we can actually measure how effective that treatment's going to be. And so with these people that have these blocked noses, and then the problem is what kind of sprays, because a lot of these things have rebound. So you want something that's safe. I've come to find this product, which is hyperosmotic saline and xylitol. Xylitol, as you know, antimicrobial, very important right now with COVID because these kinds of things are very helpful. I have people use these during the day. There's no risk of rebound and this sort of thing. So very few people have issue. So I measured the volumetric increase. The company that produced this, it was originally designed for children with respiratory problems, but I explained to them that it actually expands volume. So we did this test with two of our centers, and we collected the data to be able to demonstrate not just the effectiveness of the xylitol, but also we noticed a 20% increase in volume. And that's huge because when you change the volume of the nose, the flow rate is to the fourth power. So 1% can make a big difference. 20% is dramatic. And I'll show you, this may actually go over to occlusion if you look at patients in the way they speak. Look at this young gentleman here.
60, 61, 62, 63, 64, 65, 66, 67, 68, 69, 70. Open and close. Open. Close.
Okay, so orthopedically, there's nothing wrong. But you see how he's talking out of the left side of his mouth. Now, who would wonder, most people wouldn't correlate those kind of movements with nasal obstruction, but we'll demonstrate.
60, 61, 62, 63, 64, 65, 66, 67, 68, 69, 70. Open and close.
So that would be interesting if you were looking at occlusion and looking at different factors of movement of the jaw and not understanding that function. So that's true in the States. It's also true in Bahrain.
65, 66, 60, 67, 68, 69, 70. 61, 62, 63, 64.
And that's been true of everywhere I've been in the world. If you understand that joint pathology and acute inflammation of the jaw can have very profound effects on speech. This is a gentleman who, after intubation from surgery, woke up with what appear to be stroke-like symptoms.
My name is Richard Stats, and I am 50 years old, and I am married. I have 3 children. I've lived here in Louisville for 15 years, and I was born in Houston, Texas. So, hi, my name is Richard Stats. I'm 50 years old. I live in Louisville, Texas.
His speech now corrected with a bite registration in his mouth that decompressed the jaw at a proper physiologic position. And you can see he's restored back to normal speech.
I was born in Texas, in Houston. I had lived in Kansas before, and
so understanding the correlation and comorbidities between respiratory problems and orthopedic dysfunction, orofacial pain complaints and craniofacial pain is key. And so no one measures these things. ENTs, after they do surgery, the success of the surgery is based on healing. Did you heal properly? If you did, then it was a successful surgery. But they don't go back and measure the function of the nose. Is the flow rate restored? Is it normal? Well, that's where a technique called rhinomanometry comes in. And there's times where I have patients that I'm treating for chronic neck pain because the nasal obstruction produces there's a positioning to open the oropharyngeal airway. And when you do so, then you have this chronic neck issue. And so I'll send the patients over for nasal surgery, and I measure whether it's been brought to norm. And that's using this technique here called rhinomanometry. And so we can actually quantify whether we have good inspiration, expiration. This is an example of good flow rates. And that can actually be quantified. So we know how much resistance, low resistance, slight resistance, moderate. And these are the issues that we can go back to the ENT. There's a couple times where I've had to send the patient back 3 times until they finally got normal function and resolution of their facial pain issues. So, and that comes to, okay, well then how can we treat these patients? What are some of the modalities? I know people like to use injection techniques. I use trigger point injections, proliferative therapy injections for healing. I don't do a lot of Botox. That's not something that I've found. I understand if the thought is just to cover up the symptom, but I have a therapeutic approach. I'm actually trying to find the origin of the issue. And when I do so, it's so much easier to treat the patients. We can use something called laser, cold laser. This is a multi-lock system, which is basically 2 different wavelengths of 808, 905 that are continuous and pulsed and synchronized. And so in this delivery system, you can use this intraorally, extraorally. You can use it on the neck, the shoulders. You can, so there's has so many functions of reducing pain, reducing inflammation, accelerating the healing process. And so basically the synchronization is taking a wavelength 808, in this case that's continuous, with a 905 wavelength that's pulsed, and taking this tissue and making some very dramatic effects. There's a photothermal effect that results in reduced pain. Takes about 90 seconds to reduce the pain 50%. There's a photomechanical effect that reduces the inflammation, the edema. So immediately in the muscles in the joint, we can have better function. And then the combination of stimulation of the mitochondria, so the cells turn over at a faster rate. So we can take something that would normally take a year to heal and heal it within 3 months, which is our time frame for treating patients. So basically, you know, it's good for inflammation, muscular problems, post-surgery pain. Basically, you know, most of dentistry has you know, it's a damaging of tissue, whether it's soft or hard. And so pretty much all patients could benefit from that. But I want to talk about trigeminal neuralgia here for a second, because the studies using this technology, the studies using this technology are really interested me years ago. This is a paper talking about nerve repair, and that was one of the problems we have with nerve injuries is with the tools to be able to treat it. So nerve repair in this study, they took it was a double-blind randomized study, and they severed the rat median nerve. So here's the not operated group, the control group with no therapy, treating it with continuous laser, pulse laser, and then this combined technique, which was found to be the best resolution of that regenerated nerve. There's also, very often situations where we get muscular atrophy because the body's trying to protect an injured joint. And this technique also it can help restore muscle to proper function. I wrote an article in the for this journal, basically talking about trigeminal neuralgia and how to treat it, looking at the picture of understanding its mechanism. So this is, not an uncommon situation throughout the world, but especially U.S. And so, we have about 1 in 15,000 people that suffers, usually over the age of 50. It's a peripheral entrapment problem. So the sensory nerves and of the masseters, because masseter hypertrophy happens with patients who have increasing CO2 levels, hypercapnia, and that's what wakes a person from sleep if they have a breathing disorder. It's the increase in CO2, not the decrease in O2 that wakes you. And studies have found an increase in stimulation. Very often these patients have a cancer relationship that then causes a unilateral entrapment. So some of the, besides medications, surgeries are done. So here's the foramen ovale where the mandibular division exits, and the concern is that after 50 that we lose tonus in our vascular system, and it expands in the middle meningeal artery there, presses against the nerve. So there's a technique called microvascular decompression where they enlarge the opening place, sponge between these structures. But in my experience, I see people that still relapse after the surgery, and I've seen people that have had it done twice and still relapse, and we were able to help them without surgery. And I think it's understanding all the component parts. So a muscle spasm in itself.
A trigger point is a portion of the muscle fiber that is locked or compressed into a deep and painful spasm. Active trigger points cause an intense pain spasm cycle within the muscles, which compresses the nerves and restricts blood flow. Any disruption of normal function can cause severe pain.
So it's that peripheral entrapment. So this condition is treated centrally with surgery, but occurs in the periphery initially. And so essentially, the myelin sheath on these nerves is compressed to the point where now the capacitance is lost, and now it takes very low threshold in order to stimulate it, just simply touching or maybe cold air that causes a contraction of the muscles to set it off. And so we use membrane stabilizing drugs, anti-seizure medicine, Tegretol, Neurontin, Lamictal, Klonopin, Baclofen, Lyrica are all drugs that are used to treat this situation singularly or sometimes in combination. However, the literature shows that low-level laser is very effective for neuropathic pain. And so I'll give you an example. So this is a patient who's referred to me, Craig, 66 years old. He was referred by an oral surgeon who had been treating him for this typical facial pain, episodic neuralgia for 4 years. And he's on Tegretol, 100 milligrams 4 times a day. They tried Neurontin up to 300 milligrams 3 times a day, but it wasn't as effective. Tegretol universally is, but has greater side effects. You can get blood dyscrasias, and that's why we have to do blood work on these patients, or should, every 3 months. But there's a lot of physicians that have people on these drugs for years without ever checking them. And so from our health history, we found that he has high blood pressure. stroke history, asthma, hepatitis, and frequent awakenings. His BMI is 31, so that means he's obese. BMI of 30 or greater is the definition of obesity. These are all markers for someone that has a breathing disorder. And when we look at the oral manifestation, where we can see the worn dentition, we can see the recession of tissue from the tongue pushing these teeth out of the head very often. And we can see the coating on the dorsum of the tongue indicating mouth breathing. So everything about this, and Mallampati is a classification that anesthesiologists had developed to decide who was going to have issue with intubation. We use it for evaluation of pathology of the airway. And we should be able to see his airway, but it's clear that you cannot. So I understand. So from the positive findings, we also look, we take screenshots of the patient with a tongue blade in their mouth so that we can be aware of any occlusal cant planes. And as you can see, it runs uphill to the left. Muscles that are shorter than their resting leg tend to spasm. And so if he has a lot of activity of having to posture to breathe at night because of nasal obstruction, so you can see from the CBCT, he has a severely deviated septum, soft tissue hypertrophy, clearly a mouth breather. And I suspect from his symptoms that this airway, which looks to be quite large, collapses. And so part of my therapy at night is going to prevent the mandible from protruding as well as decompressing. And then I can treat the injured nerve. I see a high comorbidity between nasal obstruction and sleep breathing disorders. I'm not sure I've treated a patient with trigeminal neuralgia that didn't have a sleep breathing disorder. And that's probably a good paper to put together. So what we did is our treatment plan consisted of a decompression appliance for nighttime, one that prevented the jaw from protruding and had nasal dilation. So that looks something like this. And then using the laser on a weekly basis for about 2 to 3 minutes on very low 100 hertz frequency. And we'll continue the Tegretol 4 times a day. I want to send him out for a sleep study, and I also want an ENT evaluation for his nasal obstructions. So we use this EMPHI laser system, very effective for treatment of these conditions. So at 4 weeks of combined treatment of decompression, the Tegretol and weekly applications of the laser, the facial pain and jaw pain had resolved, and the pain when chewing had reduced by 40 to 50%. And that's very, very accelerated, right? Especially since he's been dealing with this for 4 years previous. At 8 weeks of combined therapy and weekly applications of EMPHI, so the pain when chewing was resolved, as well as all other facial pain. At this point, I started to reduce the Tegretol dosage by 1/3 per week. And at this point, I finally convinced the patient to get a sleep study. And well, that took some effort. And what we found is that he's a moderate apneic overall, AHI of 26, apnea-hypopnea index, if you're not familiar. So apnea is suffocation. Hypopnea means oxygen desat anywhere from 3 to 4%. And so anything 30 and above is severe. And so these people are recommended to be ventilated with CPAP. During REM, which is the part of sleep, rapid eye movement, where your body is pretty much catatonic, all the muscles are relaxed. Your ocular muscles and your diaphragm are functioning, but everything else is limp, including your airway. So that's why we see an increase, and you can see his number went up to 40 during this time. And he desatted to 82%, so that's not good. You know, your oxygenation at sea level should be 99%, and you know, and he also had periodic limb movements. So he had a number of sleep disorders, and so he was diagnosed as such. But you know, some patients, they you know, he's thinking, listen, I didn't come in for that problem. I came in for this pain, says you helped me with that. But then they start to think that the things that made them better, they don't need anymore. So they start to do away with them. So this is a good example. So at reevaluation at 13 weeks, he had completely weaned off all the medication and was symptom free. And then he decided that he didn't want to treat his OSA. And he said, I'm not going to even wear this appliance anymore. I don't think I need it anymore. At which point he started to get some tingling of the nerve again. And after 3 nights without wearing it, so he became concerned and went back to wearing it. So I said, that device isn't really designed for that purpose. I did produce it at a position of a phonetic airway to prevent airway collapse, and I have that little lip on there to prevent the protrusion, but it isn't really designed for that purpose. It was more designed to reduce the force of contraction by loading anteriorly and keeping your nose open. But I said, what? Let's just do a home sleep study and let's see how effective it is. Well, it turns out it was extremely effective, and so continued use of that device will prevent him from the consequences of sleep breathing disorder, as well as preventing the trigeminal neuralgia from returning. So the efficacy of using this kind of laser is a paper that we published, our technique. It takes about 5 minutes to do a treatment. All of the patients with inflammation of the jaw have a forward head posture, as I was describing. So when you decompress, that's the uprighting. That's why they have so many problems at the base of their skull, because that's the extensor muscles at the back of the head insertion, and carrying around this head forward position causes increased strength. Those are the patients that get headaches at the end of the day. And that the counter is the SCM, which refers above the forehead and the eye. So those are the patients who are going to be having issue as the day goes on, headache. Whereas the other patients tend to get the temporal headaches in the morning, that's mouth breathing, and then of course, elevator muscles. So we do a minute on each side of the extensor muscles, and then we do a minute and a half for the shoulders of the trapezius. We do 30 seconds for the posterior joint space, lateral, and 30 seconds with the masseters. And in that, we were able to reduce jaw pain significantly. People in our study, jaw pain was the most predominant problem. And we were able to reduce that almost 50% in the first treatment, 25%, 9% until we had resolution. Now, the indications for a laser are also throughout all dentistry, but particularly neuropathic orofacial pain efficacy has been published in the Journal of Orofacial Pain and Headaches just this year. So, and the conclusions that low-level laser therapy seems to be effective as a treatment option for different neuropathic problems, trigeminal neuralgia, odontalgia, and burning mouth syndrome. So these are some really tough situations that usually require medication to stabilize. Also in the orthodontic world, laser has been found to reduce treatment time anywhere from 34 to 50%, depending on what study you read, and reduce pain from the orthodontic process. They also accelerate the orthopedic development. So for transverse expansion and this sort of thing has been found to be efficacious. In each of these situations, you can take a look at the orthodontic literature for that. Also, the endodontic literature shows that laser is very effective for reducing postoperative discomfort and increasing mast cell response to tissues. That's just the tip of the iceberg. An hour is a very short amount of time to be able to get into these things in depth, but I wanted to give you just an overview. I know that was very fast, but there's so much I wanted to share and very little time. We have a few minutes if we can, if you'd like. You can go on my website to find more information about the things I'm talking about if you have interest. and reading about some of the things. This is a book that I just authored that came out about 6 months ago. It's mostly an introduction, really patient kind of thing, but it explains the relationship between airways and function, and I show examples of how we treat adults and children for these kinds of problems. So I'm very open to take questions at this point. So let's.
Hi there, Stephen. I'll just have a look now to see if we have any questions. One moment. There doesn't seem to be any questions. It's a very interesting webinar. Thank you. Has anybody got any questions for Stephen? No, Stephen, there doesn't seem to be any questions. You must have covered everything, but it was very interesting. Thank you very much. But Stephen, actually, bear with me. Here we go. We do have one now. Can you advise on the management on early childhood apnea?
Well, yes. Actually, that's something that I'm quite involved in. Currently, I'm working with some of the top sleep physicians in our country. Judy Owens from Harvard, Dr. Rakesh Bhattacharjee here in San Diego. And we've developed a visual screening tool that we're validating right now. So we're going to collect 500 cases that then we're going to publish, demonstrating what should a dentist look for that would indicate likely a problem for sleep breathing disorders. That is validated with something that's called a pediatric sleep questionnaire, PSQ. That is has been validated. So we have 3 stages of this research that we're going to do. So the first is validating the tool. The second is testing it with sleep studies, PSGs, and because eventually this tool is going to be one that is used by dentists to refer to children to sleep physicians, but also for physicians, sleep physicians who have already diagnosed children, to see that if the child has these malocclusions and these facial deformities, tongue tie, all of this kind of thing, that they know to refer to a dentist who's been educated in treating children in that way. So, yeah, we're right in the midst of that, and really exciting time because people have been treating adults for a while, with oral appliance therapy and different things. But what about the children? And so those consequences can be lifelong. So very, very important.
Okay, Stephen, thank you for that. We have a couple more questions which have come through. Could you recommend a comprehensive source for the relationship of malocclusion and TMJ problems and the effect of occlusal adjustment on relieving these problems?
Well, in my experience and in the literature, standard of care is not to make any permanent changes to dentition as a primary treatment. The reason being, I just showed you how even nasal obstruction can change the relationship. Inflammation of the jaw can change that. Muscular dysfunction, disc displacement. There's any number of things that are dynamic, including postural changes. So all you need to do to understand postural changes is put your head back, put your teeth together, and draw it down to feel your jaw sliding forward. Put it to the side, like, and any combination of head position is going to change. It's a very dynamic. So what I do is I evaluate the occlusion at the end of treatment when I have stability and control of all the variables. So the inflammation, the restoration of proper functional breathing, upright posture, and then look at how teeth fit together, and then the determination at that point. So I use adjustments as the finish to the process, not as a starting, because there's too many dynamic changes that will affect that outcome.
Okay, thank you, Stephen. We have another question here from Maxine. Does your sleep apnea device posture the mandible anteriorly in order to
No.
open the airway? Okay.
No. We just, I published the phonetic technique, which is a three-dimensional technique of positioning and giving tonus to the airway without protruding it. Because if you have a cant and you protrude, you're likely to have a disc displacement issue in those situations. So I do not use that technique. We published just at the end of last year a head-to-head of the phonetic technique or sibilant phenome registration versus the George gauge technique, which is what I think this person's asking about. And in our study, we took 40 patients using each technique in different offices and found that the phonetic technique that we use that doesn't protrude the jaw was equally as efficacious without protrusion. And also, we had less titrations. Because you already have an ideal relationship, there's no need to titrate it. So in the study, the people who used the George gauge, they titrated 2.7 times, where we titrated 0.8. And so the thought is, well, what's the big difference? 0.8, 2.7 doesn't sound like a lot. Well, it is a lot if you've already started from 60% of protrusion and then you did your titration. So as a person who treats joint pathology, that's not something I have interest in.
Thank you, Stephen. One more question here. How will you differentiate the diagnosis between normal I can't even say that, sorry. I don't know if you can see this, Stephen. I'm not quite sure. Can you see the Q&A box there?
I think I got the understanding of the question, which is how do I tell the difference between a tooth pain and referred pain? So the answer is the standard tests for determining tooth pain, hot, cold, percussion, all these kinds of things. And then palpating the muscles that refer. So the elevator muscles like the anterior temporalis to the front teeth, the masseters that refer to the posterior teeth, the buccinator. Most people don't evaluate the buccinator because that inserts right above and below the posterior teeth. And very often a painful tendon insertion of the buccinator will refer to pain to the teeth. So that's something that people don't check because the buccinator is the anterior portion of your airway. And so these patients with airway problems, they often, have painful teeth or breaking their teeth because of the clenching as a result.
Thank you, Stephen. There's been a lot of great comments there to say, great webinar, thank you, very important. And we at Tips and Training, we would just like to thank you. Really appreciate you taking the time today, to give us a fantastic lecture.
Well, thank you for the opportunity. You have a wonderful evening.
You too. Have a lovely evening. Take care, Stephen. Bye-bye.
Bye-bye.